this group, we're going to be talking about colon cancer, your heart attack and congestive heart failure, Alzheimer's disease, common orthopedic problems, and oral disease, your teeth. We know we all got some bad teeth, so we're going to talk about that too. And that leads to other diseases. So let's have them, I'm going to bring them up, introduce them. First of all, we have Dr. Kevin Dancy, who is a general dentist extraordinaire in Atlanta. Tell us who you are, Brother Dancy.
Thank you, brother. Dr. Kevin Dancy, born and raised right here in Atlanta, Georgia. Pledged Omega Psi Phi at Morehouse College in the fall of '92. Practicing dentistry over 25 years right here in Atlanta.
All right. Brother Dancy, tell us what effect the oral cavity has on overall health and how it can affect that.
Great question. So you know that the mouth is the main gateway to the rest of your body, right? So it matters what we eat, how we ingest medicines, how we ingest foods, what we ingest that will affect our overall health. So being mindful of the risk factors that could cause oral disease and other diseases in the body mainly starts in the oral cavity or the mouth.
This is a question about our children. But when should kids start seeing the dentist?
So the American Academy of Pediatrics feels that by the age of 1, we should take our kids to the dentist, or at least 6 months by the time their first tooth erupts. And what that does is not necessarily a cavity thing or a disease thing. It's more so making sure that the kid feels comfortable and acclimated to someone that they would see for the rest of their life, right? So we've all heard of white coat syndrome. We don't want kids to fear the dentist. We want them to, to make sure that we are their friend and that we will be treating them from one tooth all the way up to the rest of their life.
What are some risk factors that could impact the health of my teeth? Risk factors that could affect.
I think the main risk factors that could affect overall oral health would be cigarette smoking, cigar smoking, drinking, excessive drinking, or a combination of all of those. So if you drink a lot and you smoke, you drink a lot and you cigar smoke, it just makes the environment of the mouth more permeable to ingesting these carcinogens that could lead to oral cancer. So those are the 3 main risk factors that people do socially that could affect oral health.
Question I know a lot of people have: the difference between traditional braces and the clear align.
So everybody wants brighter, straighter teeth these days. I mean, cosmetic is on the rise, but a lot of adults don't necessarily want to do the old school braces. I think the main difference is the old school braces or the metal braces that we see, they stay on your teeth for the duration of the treatment. The clear aligners are changed by the patient ever so often to achieve the goal that we've set out to do. So I think the purpose, and people are looking for ortho treatment, is if you know that you are not going to be responsible enough to change those aligners or do them as often as you need to, let's go with the conventional braces to achieve the goal that you want quicker.
Okay. I got so many questions for you, but we're going to come back.
All right,
come back to you. We're going to shift gears and go to colon cancer, another disease that affects our community at an astounding rate. We have Dr. Luther Burse. Tell us who you are, Brother Burse.
Yes, my name is Dr. Luther Burse. I'm a board-certified gastroenterologist right here in Atlanta at Emory Midtown, right down the street on Peachtree. And I pledged at Psi Chapter, Morehouse College, Spring '84. And, I'm here to talk about colon cancer. You got to get yourself checked.
And colon cancer, as you can hear in his voice, that's one of those preventable diseases. It's preventable. So talk to us a little bit about that, Dr. Bird.
Well, Frank, you're right. Colon cancer is one of the most preventable cancers that we have. Let me tell you, it's one of the most preventable cancers that we have. Screening, early detection, cancers can be removed through the colonoscope and not require surgery, chemotherapy, radiation.
And it seems that we're starting to see colon cancer in a lot younger age group. Any ideas to why that is?
Well, clearly, diet is a big thing. Now, genetics play a role also, but processed meat is a killer. Red meat, we're not eating the fiber. We're not taking in the vegetables that we should. You know, we're eating a lot of fast food, a lot of junk. People aren't exercising, and just we're seeing more and more. I've had a couple 20-year-olds with colon cancer.
Wow.
So now I don't know more. That's probably more a genetic thing, but we're seeing it younger and younger, and I'm definitely seeing it more in the prison population, and that's directly related to processed meats. That's all they eat.
Tell us the screening for an average risk person
Okay.
versus someone that has high risk. What would make somebody a high risk for colon cancer?
So high-risk person would be someone with a family history of colon cancer, and usually, now when we say family history, you know, that's not, you know, cousin Ray Ray. That's your sibling or a parent. Now, if you have two aunts or uncles on the same side of the family, that's considered high risk also. And people that have conditions called inflammatory bowel disease, ulcerative colitis, things like that, they also are an increased risk.
So the screening for a low risk, what's the
I'm
difference
sorry.
in the screening?
So 45, you keep talking about 45 is the new 50. So a few years ago, the screening number was changed actually for African Americans because we have a higher incidence of early cancer than anyone. So 45, you should be getting your colons checked at 45, not 50. Start at 45. Obviously, if you have a family history, then it's totally different. But those that don't have any family history, no risk factors, you start screening at 45. You want me to go into?
We'll come back.
Okay.
So make sure we get everybody in there
Okay.
first. And next, actually, on my list, we're going to talk about something that really affects us, our heart. Our heart. And we do so much damage to our heart ourselves. We already have some genetics involved, but we do so much damage to our heart. And again, I know everybody in this audience has a friend, a colleague, a relative that has died suddenly from heart disease. Had no idea they had heart disease. So we have a cardiologist, an interventional cardiologist, one of our brothers from Kappa Alpha Psi. Everything I ask him to do, he always comes through and helps out with me. So I'm so happy he's here. Welcome, Brother Brown. Tell us who you are.
Good morning, everyone. I'm Marcus Brown, interventional cardiologist here in Atlanta at Northside Hospital. Proud member of Kappa Alpha Psi Fraternity Incorporated, representing the Noops in here. I appreciate the brothers of Omega Psi Phi not harassing me too much. But I appreciate being here, Frank.
Okay. All right. So it's something real simple. We think it's simple, but it might not be simple to the audience. What is a heart attack versus a cardiac arrest? Is there a difference? Are they similar? Tell us what that is.
Yeah, well, that's a good question. They are not the same thing. So when we talk about cardiac arrest, simply, what we're talking about is the heart stops, right? So there's a number of things that can actually cause cardiac arrest. You could be born with congenital heart problems that could cause an arrhythmia, which is a dangerous heart rhythm that will make your heart stop. You can be born with a muscle that's too thick. You can be born with your arteries in your heart coming from the wrong location. So there are a lot of congenital things that can actually cause your heart to stop. So cardiac arrest is just a heart stopping. Now, heart attack can cause cardiac arrest, but they're not the same thing. A heart attack is actually a process where you have plaque buildup and the plaque actually ruptures and you form a blood clot in your vessels that stops your heart from getting enough blood supply. When your heart muscle doesn't get blood supply, that muscle starts to die, and then you can develop arrhythmias and die from that. So you can actually get cardiac arrest definitely from a heart attack, but you can get cardiac arrest from other things.
And tell us a little bit about some of the risk factors for heart disease.
Well, it's good. So, you know, when we talk about heart disease, there are risk factors that make you more prone to actually developing. So just like I said, heart attack is caused from plaque buildup in the coronary arteries. There are conditions that make you more prone to building up plaque. So first of all, age, which is non-modifiable. We're all going to age. We're all going to get older if we're blessed. And so once you become over the age of 40, you actually enter into a risk of developing coronary artery disease. If you have a family history where someone has actually had coronary artery disease or sudden cardiac death at an early age, that's a risk factor for you as well. Now, those modifiable risk factors, high blood pressure, diabetes, high cholesterol, smoking, obesity, sedentary lifestyle, those are all other things that make you more prone to getting heart disease. And also, and I heard Frank talk about getting a lipoprotein A. That's something, lipoprotein little a is something that's actually we're getting more and more information on. We're going to have treatments out in a few years, but we know that there's a strong correlation between having an elevated lipoprotein A and having coronary artery disease.
Talk to us briefly about some other good screening things that we can do for average risk or even high risk people.
Yeah, and good, because I have a lot of patients who come in and they have the risk factors that I mentioned, or they have a family history, or some of them just say, hey, I had a family member or a friend that actually died suddenly. I mean, I think we've all heard of those situations like Frank mentioned where you saw somebody or talked to somebody the week before, they were doing just fine, and then they suddenly died. So one of the important things, and one of the things that we've been using more often over the last 10 years is a coronary calcium score, right? And so you can ask your doctor about this. Your primary doctor can order it. I have a lot of patients that come to me to order it. But what that is it's actually an X-ray. It's done with a CT scanner, but it's actually an X-ray. It doesn't require dye or anything. But we can take a picture of your heart and your arteries and then see if there's any calcified plaque, meaning any calcified buildup of something that could later cause a heart attack for you. If we see any, we give you a score, where you'll get a score anyway, even if we don't see any. Because if we don't see any, you get a score of 0. But based on how much we see, we give you a score, and then your doctor can then use that score to help risk stratify you to say, hey, if you're low risk, intermediate, or high risk for having a cardiac event in the future. Another screening test, like I mentioned before, is a lipoprotein A, because we know that when you have lipoprotein A, this is something you're born with. The level doesn't change as you get older. You either have it or you don't, but we know that there's a strong correlation between having an elevated lipoprotein A and having coronary artery disease. When you go to your doctor, make sure you ask for a cholesterol panel, because we know traditionally that having high cholesterol, definitely the bad cholesterol, the LDL, the low density lipoprotein, is associated with having events in the future.
All right. We're going to shift gears again. We're going to come back. You all will get a chance to ask your question. We just want to keep it going. Next, we're going to talk to another one of our internal medicine doctors who has a special expertise in hypertension and kidney and that interrelation. And she also has a strong relationship to Delta Mu Mu chapter. So let's hear from.
Hi, good morning, everyone. My name is Natasha Travis Bailey, and I was asked to come here by Frank, but I got the little nudge at home because my husband is also a member of Delta Mu Mu, Derek Bailey.
Hey.
Some of you may know. I am a proud member of Sigma Gamma Rho Sorority Incorporated, and I pledged at Beta Rho chapter in spring of 1995 at Loyola University in Chicago. Thank you so much for coming out. I put them all up front so that we can look at all this gold. It's beautiful. We love it. So I'm an internal medicine physician, as Frank said, and I work at both Emory University Hospital Midtown and Grady Memorial Hospital not far from here. I work with Jada Bussy Jones over there, who actually is my boss. And so when I saw that call come in, I was like, oh no, I better do this one. So I'm happy to be here. Thank you for having me.
Thank you. Tell us just what is hypertension? What is high blood pressure? How do you diagnose it? What causes it? That's a lot, but
Yeah, it's a lot. It's a lot, but it's a really good question, right? So, the force of your blood inside of your blood pressures, blood vessels pushing against the walls of the blood vessels, that is pressure, right? So the high blood pressure is when we look at the numbers that you get. What numbers am I talking about? So when you get your blood pressure checked, the doctor will put a cuff around your arm and squeeze a gauge, and those numbers they give you will be in millimeters of mercury. So that is actually pressure. You get two numbers. The set of numbers you get will have two numbers. The top number, which is the systolic number, and the bottom number, which is the diastolic number. When those numbers are 130 on the top or higher, or 80 or higher on the bottom, we diagnose you with hypertension. You will need to have two readings on two separate occasions to get diagnosed with high blood pressure. So every adult should have their blood pressure checked at least once a year. Like we've been saying, when you go to your doctor, if they don't check your blood pressure, ask them to check your blood pressure, because that reading will help them either diagnose you or put you in the normal range so that you can reduce your risk of other chronic medical concerns.
why is hypertension bad? Why is having a high blood pressure bad?
That's also a good question, and I know that you all have heard your doctor say you don't want your blood pressure to be too high because you don't want to get a stroke. We talk about other chronic, life-threatening problems that can happen if your blood pressure is uncontrolled. We're talking about chronic kidney disease in particular. We're talking about heart disease and heart attacks in particular. We're talking about strokes in particular. There is so much more that we are trying to prevent by reducing your blood pressure.
And is hypertension in blacks different from hypertension in other races? Is it treated a little differently?
That's also a very loaded question. All of us are saying the same thing, and this is why we ask you to go ahead and see a provider that you can communicate with, because the treatment of the high blood pressure could be a variety of things. It could be medications, it could be lifestyle changes, it could be, dietary changes, whatever that it might be. And the treatment should be tailored to you. It should not be a guideline directed medication that they pull out of thin air. I want you to talk to your provider to say, which one of these medicines would be best for me, or should I start with the lifestyle changes before I do that? And when I mention lifestyle changes, I'm referring to things like if you're a tobacco user, if you're a nicotine user, not smoking. If you are one of those high salt eaters, and I'm guilty as well. I had 2 bags of potato chips while I was on a golf cart yesterday. But if you are one of those people who just crave that salt and you're having high numbers of milligrams of salt per day, if your weight needs to be treated. So we've been talking about obesity, and obesity is very well linked with high blood pressure. These are things that you can do without medications to help either your doctor to help with the combination with medication, or to even use it to treat your high blood pressure.
Okay. I got so many questions
You
for you,
got-
but we'll come back. Let's keep it moving. Next, we have a brother, a member of Alpha Phi Alpha Fraternity Incorporated, and he's going to talk about something that's near and dear to me and a lot of us. My mother and grandmother died of Alzheimer's disease, and I'm sure many of you have family members. Many of you have been caregivers, and so that is something, and it really affects our community a lot more. We don't talk about it that much. He's also a gerontologist, but tell us who you are, Dr. Trammell.
Good morning. Is it on? Okay.
Yeah.
Good morning. I'm Antoine Trammell. I am an internist. I also have some expertise in memory disorders. I'm on faculty in the School of Medicine at Emory in the Departments of Medicine and Neurology.
Yeah.
Can y'all hear me now?
Yeah.
Oh. Did you hear anything I said at all? All right, let me start over. My name is Antoine Trammell. I am a board-certified internist, and I also have some expertise in memory disorders. I'm on faculty in the School of Medicine at Emory in the Departments of Medicine and neurology. So in neurology, I'm part of the Alzheimer's Disease Research Center, where I lead multiple studies. I also co-lead our outreach, recruitment, and engagement core. In medicine, I lead a clinic for memory care disorders through the Georgia Memory Net.
Tell us a little bit. I mean, there are different types of dementia. Just kind of briefly talk about the other types, but tell us first of all Alzheimer's and what that is. Most people have heard of that, so tell us about Alzheimer's and then some of the other types.
So let's start by being clear on the difference between Alzheimer's disease and dementia. It's a spectrum. Right? There are many causes of memory and thinking issues. High blood pressure, heart disease, inflammation from poor teeth, stress. Right? All of these things can lead, and Alzheimer's disease, of course, all of those things can lead to memory and thinking problems. When those problems become so severe, meaning your memory and thinking issues that you need help functioning, that's dementia. Okay? Dementia is an endpoint. Right?
When should a family member get concerned about another family member? Because we all, I feel like I have dementia every day. When should we get concerned? What are some things that we should get concerned about?
That's a loaded question. Because if someone is under stress and they're having trouble managing things and they're forgetting something, that may not be a point of concern. But when your loved one is starting to repeat questions and repeat conversations, when they're forgetting things, keys, phone, that it's very difficult to forget, or when you just have a suspicion that something is not right and you cannot explain it, take action.
When my mother and grandmother had Alzheimer's disease, one of the biggest issues we had was taking care of their agitation. And I'm sure if you've been a caregiver, that is a major problem because it feels like there's nothing you can do. Everything you do makes it worse. Is there anything you can do about the agitation? Any medications? Anything that we should do to try to mitigate that?
Yeah, so agitation can occur early on because people just don't remember or they're having trouble performing their daily activities. So structure, routine is helpful. Later in disease, when you get to the dementia range, agitation can also occur, and that's much more difficult to treat. But structure and routine are also helpful. I try to avoid medications as much as possible because that can make the agitation worse in some cases, right? So if you're a caretaker and you find your loved one being agitated, one of the best things that you can do is create the routine where they are very active throughout the day so that they can be tired and sleep well. Right? If you're concerned about wandering, then give them a space where they can move around safely, say a fenced-in yard. And some basic things like eating can cause agitation. You want to minimize, there are certain types of spoons that you can use, but you also want to minimize distractions during a lot of everyday activities.
All right. And we keep hearing about, reading about some new medications to treat Alzheimer's. People think, oh, it's the cure for Alzheimer's. Tell us about any new medications on the horizon and how they may affect Alzheimer's.
There are game-changing medications that are now on the market to treat Alzheimer's disease in particular. Right? One of the downsides of these medications is that in the clinical trials, the research studies, there were probably 100 black people in the studies, like across the planet, right? However, I can tell you that black Americans are affected twice as much by Alzheimer's as other populations in the United States. Okay? So higher risk, but yet there's less information about treatment. Okay? What these drugs do is they go into the brain and they dissolve the plaque. So Alzheimer's in particular is a buildup of a plaque called amyloid. And that can lead to something called tangles. Well, the idea is if you remove the first protein, if you remove the plaque, then you can slow down the progression, and it works. Right? So they are game changers. However, knowing how well they can work in Black Americans is something that we're still learning.
All right. Again, keep your questions. Next, we have, last but certainly not least, Dr. Wendell Cole. He is a world-renowned orthopedics podcaster. Very well known, but one of my former students as well. And just tell us who you are and what you do.
Yep. Good morning, everybody. My name is Wendell Cole. Just like you said, I'm an orthopedic surgeon. I specialize in sports surgeries. I did medical school at Morehouse School of Medicine with Dr. Jones. I pledged Omega Psi Phi at Georgia State University. Rude out. And yeah, so I do orthopedic surgery, and I also do a podcast, and I help educate orthopedic surgery trainees.
Okay. And he's doing some amazing things. Him and his group, Resurgence Orthopedics, they do some amazing things in the DEI space. They're really trying to help us create some more orthopedic surgeons.
And I work with Resurgence Orthopedics at Johns Creek.
How many Black orthopedic surgeons are there, percentage-wise?
Less than 2% of orthopedic surgeons are Black. Less than 2%. It's a very, very minute number, but we're trying to increase that with different programs and increase, diversity in the field of orthopedic surgery and medicine in general.
They're doing some great things. Tell us, what is an orthopedic surgeon, and what are some of the things that you all take care of?
So an orthopedic surgeon is a surgeon that operates on joints or bones or any of your extremities, so any of your arms, your legs, your hips, your pelvis, things of that sort. And so you may see an orthopedic surgeon if you have knee pain and you have knee arthritis, or you injure your shoulder, you slip and fall and twist your ankle. Those are all reasons that you may see an orthopedic surgeon. And when you see them, they'll see you, they'll evaluate you, maybe get some x-rays, and then there's all different treatment options depending on what your injury is or what the pathology is.
Let's talk about one thing that may affect a lot of us here, arthritis. Arthritis. Are there any new treatments, any new ways to manage arthritis?
So just to back up a little bit, what is arthritis,
Okay,
right?
yeah.
So at the ends of our bones, we have what's called cartilage. It's a smooth, slippery substance, gives the bone some cushion. So anytime you have chips or wear in that, we call it arthritis. So we don't have a way to grow the cartilage back, but we just try to manage your symptoms. So there are different treatment options. One is lifestyle modification is the first one. Being more active, good diet, those are some of the main things. And then next, there are different kinds of injections that we have. We have steroid injections that you may have. There are gel injections. So there's a variety of injections that your orthopedic surgeon can offer you, as well as physical therapy, and that helps a tremendous amount. So there are a lot of different conservative treatment options, and then when it gets to the point where it's bone on bone and there's no cartilage, some people may need a joint replacement of some sort.
That segues right into my next question. Talk to us about, I remember a few years ago, if someone had a hip replacement or a knee replacement, we were talking about a long time in the hospital, followed by a long time at home in physical therapy. And nowadays, it's almost in and out surgery. Tell us kind of some of the indications for that and how that's done.
Well, yeah, that's a great point that you make there, because there's been increases in technology or advances in technology that have allowed better implants, different, more minimally invasive surgery. So the indications, when do you need surgery, when should you consider a joint replacement? So that's if you've tried all the different things. You've tried physical therapy, that's not working. You've tried an injection, that's not working. And it's starting to interfere with your daily activities. You're having growing pain when you walk around. You say, I'm not gonna go out to eat lunch today because my hip hurts too much or my knee hurts too much. And nowadays, if you're looking at getting a joint replacement, a lot of these are done outpatient actually. So outpatient meaning you come in, you have the surgery, you go home the same day, or you stay in hospital for maybe a day or so. But the techniques for surgery have improved over the years, and we're able to do this again on an outpatient basis a lot of the times, or just one night in the hospital, and then you go home the next day.
Would it be safe to say if your orthopedic surgeon tells you you need your hip replaced or you need your knee replaced, you should have it done. Because we're always going around shopping around for a doctor to tell us we don't need that. But if they tell you you need that, should they have it done?
Well, at the end of the day, it's on the patient, right? You know, at the end of the day, it's more on have you done the treatment options? Have you tried all the injections? And is it to a point where you can't live with it? When it's at a point where you can't live with the pain, you can't live with the discomfort, then you can consider a joint replacement. But there are a lot of conservative treatments for arthritis that you can consider before jumping into getting surgery or getting your knee replaced or hip replaced or shoulder replaced, etc.
You talked about injections. Tell us what kind of injections you're talking about. Are we talking about plasma injections?
Yes.
And I know we have some weekend warriors in here. And so talk to us a little bit about that. Do those really work?
Yeah, there are a multitude of different injections that you can get, right? So one are steroid injections, probably the most common one that you go into the office, get an injection in your joint, in your knee. Another one is called a gel injection. This is kind of like WD-40 for your knee or for your other joints. It helps smooth things out. What you're referring to is called PRP or platelet-rich plasma. So basically what this is you get your blood drawn, we spin out the blood, and we take just what's called the platelets. The platelets have anti-inflammatory factors. They work at decreasing pain, improving function, and we inject that back into the joint or whatever the area is that's causing you pain and discomfort. And so there are mixed studies, but it actually has pretty good results for treating a lot of different pathologies. And then you have what's called stem cells, which they're mixed results for stem cells, but it can help decrease pain, decrease inflammation, and improve function as well.
Okay. All right. First of all, let me say I'm impressed the audience is still here. Y'all haven't left. You're still here. And now it's your turn. We actually earlier than we were supposed to be. My wife is always saying I take too long to do these things, but because I like to talk. Let's get some of your questions now. And you can ask any of the topics that we talked about before, or it could be something else we haven't talked about. We got a question right here.
So my question would be, because I lost my sister last year because of diabetes, and what I saw in her was a storyline that she had created within her mind, and it led to not taking medications properly, and it led to her lifestyle. But I'm also seeing that also in the elderly that I work with, there's this storyline that they're repeating, and it comes off with the aggression. So what are we doing? What do I need to do as a caretaker or as a loved one to ensure that they're all right and help them in those transitions?
Are you specifically about diabetes or just in general?
Just in general, but there was diabetes.
I think she was talking about diabetes. You're referring to something, the storyline?
Storyline, like, everybody has, they're going to
Yeah.
believe what they want to believe. They're going to try to make you believe. So how do you deal with that?
Okay, I'm going to try to answer this question. So you're referring to saying that maybe we just have diabetes, but you found out that it's more than diabetes. Is that correct? Right. So when it comes down to knowing all the diagnosis that could potentially cause death or be harmful to a patient, it requires you potentially, if you're able to, going to the physician appointment with your patient, your parent. Honestly, sitting there to be the person to listen to what the doctor says, you are another set of ears. They might not remember anything, but I told them they have diabetes. You are the next set of ears that can say, these are the things that you also have and why you need to take the blood pressure medicine or the diabetes medicine. It is your provider's responsibility to explain to your parent what it is that they're taking and why they are taking it. You should not be taking medications that you do not know why you're taking them, right? So with that in mind, go with your mother or go with your family member to the meetings with your doctor and listen and determine why they're taking it so that they clearly understand where the medications are coming from, where their diagnosis is, and things like that.
I think you have that pretty good. Another question.
So the short question is, how different are we from white people when it comes to the chart? But I'll explain. For example, I grew up always on the charts saying morbidly obese, no matter how much weight I lose, all these different things, but healthy. Right now, I mean, I've just come off of losing almost, 90 pounds. I'm a cancer survivor, had to have a hysterectomy, all that. Yay, thank God. So, and I have low cholesterol, low blood pressure, resting heart rate is usually around a 60, aerobics instructor for several years, but I've just always been heavy. And every time I go into the doctor, but you're morbidly obese. And it's like, are these charts accurate for us? Now I know, right? Because I feel good, I feel healthy, and I actually now just finally got a black doctor in Columbia, South Carolina, who she doesn't harp on that as much. But it's like, at what point is that accurate? Because I feel good, I feel like I look good, I'm moving, all those different things. Are those charts really about us too, or is there a different way to measure health in terms of black people, particularly black women?
That's fantastic, and I think one of the things that I used to have the BMI charts posted on my doors, right? And then after a while, I was like, man, this doesn't even apply to folks sometimes, right? So BMI was developed by insurance companies in the 40s for Caucasian men, all right? So their bone density, and when I talk about BMI, I talk about your body mass index, right? It's a height-weight ratio. And you get a number over 25, and you're all of a sudden overweight, and over 30, you're obese, okay? So I say right off the bat, it doesn't apply to women. It doesn't apply to black people. It doesn't apply to Asians. All right, so there's a lot of folks who do fall outside of that BMI category. So that's one thing. We tend to use now waist circumference more so because there's a better correlation with insulin resistance and progression of diabetes and a lot of these medical things. But also don't harp on the number. Harp on a goal for lifestyle and health. Right? Maybe reduction of cholesterol, reduction of blood pressure, less arthritis, less heart disease. So strive for that and not necessarily just get caught up on the number, and talk to your doctor about that, because the doctor needs to have an understanding of that as well, as those don't apply to everybody.
Question. Yeah.
So I had a question regarding menopause and what Dr. Burt thinks regarding HRT.
Dr. Burke?
Your thoughts regarding your thoughts regarding HRT. I know there are some negative things about it, but my gynecologist highly recommended it, so I kind of wanted to get your take.
Let me tell you, most of the problems that women experience in the peri and postmenopause is because of the lack of estrogen. I love estrogen. Estrogen keeps, it's bone protective, it's heart protective, it's brain protective, but it has to be given in the right patient. Some people cannot, take it, of course, family history, personal history, certain things, but I'm all about the HRT, personally. And I will say something, I think Frank, Dr. Jones asked the question, or someone in the back, and everyone kind of paused on the stage during the first hour. We are not taught everything. You're gonna ask me to help you with, a meal plan? I'm trying to figure out what I'm gonna eat. What you talking about? Because that's not what our training is in westernized medicine. And I'm saying that because same thing with hormone therapy. A lot of the things that folks like me and where's my girl at? There you go, whoop, whoop. It's because of my colleague that I even learned about hormone therapy. Because of her. So we, as the black community of physicians, are even educating ourselves to help our patients. But HRT got a bad rap, 2002, Women's Health Initiative, and what they gleaned after that was when we pulled all those women off of it, more women died.
So, as the breast specialist, where breast cancer is hormone related, I agree with you 100% that it has to be a conversation with you and your physician when they look at your family history, they look at your personal risk, and then can make a recommendation. We don't want, as breast specialists, to have you suffering through life. Quality of life really doesn't matter. So I have patients who come in and they say, can I take it? You know, yes, it can be associated with hormone-positive breast cancer. We don't want to give hormones for hormone-positive breast cancer. So your risk assessment is super important. That's all.
Another question.
Good morning. Thank you all for this session. My question was, a common thing that I've heard is that we're high risk. We're high risk. Is that because we were never studied? Is that because of something that we do all the time and now we're just high risk? Because I keep hearing that. Another question or part of it is we continue to hear a lot of different educational things from a lot of different people. But what is it that we should be doing to change our lifestyle? I hear people say, wait, you should have sea moss, you should have black seed oil, you should have this. I feel okay. I don't think I need to have any of it. But what should we do? Because we hear that, well, our food is not giving us everything that we need. What do we do? I mean, I feel like we're inundated with a lot of different information, and it's mind-blowing.
So in terms of your first question, actually both questions are good. We're high risk. I've given some lectures, and you can find them on YouTube, for a men's program at our Alzheimer's Disease Research Center in Emory. In one of those lectures, I show a map from 1860 of the Southeast. The dark areas show, take a guess, enslaved humans, all right? And I overlay it with a map of the Southeast from 2016 that shows areas of high mortality, right? So across over more than 150 years, you see that areas that had the highest concentration of enslaved humans, Black Americans, still have high mortality today. What's going on? Lack of healthcare access, right? For the young lady who you asked about BMI, well, one of the biggest risk factors for any disease is lived experience, right? And that's going to be your healthcare access. That's going to be your stress. So it's not so much that we were not studied, because technically we were studied. It just wasn't always voluntary, right? But the access to routine care was not there, and that led to a dependence on what's called homeopathic or traditional remedies, which can work, right? Now, as far as your second question about the information, sea moss, black seed oil, there are a lot of things out there. People have stories to share, but the one thing you don't hear about sea moss, black seed oil, whatever, you don't hear about the 100 people who may have died when they took those remedies. I'm not knocking them at all, right? But the key to a better life is to let go, or I should say the key to better health for our communities, maybe letting go of the mentality that we have, I'm not going to claim it. You have to claim it. You have to claim your health. You have to start by living a clean life. So if you live well, eat well, then you can be well and age well, right? Healthcare is available. It's not the enemy. However, we have to accept the fact that across that 150-year time, all of that experience influenced our mindset, right? So we may carry that with us. And it's a lot to look inside yourself and say, and to trust the person who's in front of you that they have your best interests at heart. Right? So you have to advocate for yourself, as one of our panelists said. Claim it and take advantage of the tools that we have today.
Before you give him the mic, I gotta ask a question that might get me put out of here today, but that's okay. I wouldn't be doing what I'm supposed to be doing. whenever I sit down with my frat brothers, we having a great time playing golf, hanging out, having a good time. What's the first thing we do? Pull out a cigar. Pull out a cigar. I don't know when cigars became fashionable, but it got quiet. It got real quiet in here. We pull out a cigar, pull out some liquor, pull out some fried chicken, and we sit down and talk trash. Cigars are worse than cigarettes for you. 10 times the amount of nicotine in a cigar than in a cigarette. 10 times. Well, I don't inhale, dog. I don't inhale. Dr. Dancy would tell you, well, you just setting up for oral cancer. And then on top of that, now the women start smoking cigars. That's my pet peeve. I'm finished now. The bruh's gonna come pull me out of here. But if we could do anything, cut down on the cigars, cut down on smoking, cigarettes, cut down on the alcohol intake, cut down on the sugar, cut down on the sodium. I'm guilty of that. Sugar, sodium, sleep, exercise, take care of our mental health. Oh, look at the bruhs coming to get me. They come to get me, come talk about the cigar. We getting close to time. Go ahead, bro.
So the cigars and the smoking and all of that, that can kind of treat the symptoms. But my question was, we talked about heart disease, breast cancer, colon cancer, all these different things, all of which have been shown to be connected to childhood trauma. What can we do to convince, because we'll normalize the trauma, and my trauma wasn't as bad as the neighbors, but what can we do to address childhood trauma as it affects all those different things throughout our life?
Fantastic question. We could have a whole session just on that. Anybody want to touch on that? That's such a deep area. Anybody want to touch on that?
June is it Men's Mental Health Month? Yeah, I
Yes,
think June
it
is
is.
Men's Mental Health Month. Trauma should not be normalized. And you have to be open. It doesn't make you any less of a man. It doesn't make you weak. It actually makes you stronger. Anyone else want to? Because that's such a deep, that's a very deep question. Because we're just not socialized and conditioned to really talk about it and embrace it. And I think that we have to really shift the narrative within ourselves and our families to be more open to talking about it so that we can release it, let it go, grow, and move on.
I was just going to say quickly that on the medical community side, we are working on trying to ourselves understand what this means. There is a whole subset of doctors working on informed, what is it called? Trauma-informed care, where we kind of take that perspective in when we're treating you. So instead of being like, why don't you do this? It's more of a holistic look at you. And a lot of times you have to be open to having that communication with your doctor when that comes up. It's called trauma-informed care.
We have two people. Oh, okay. You got him? Okay.
This is not really a question. It's just something I feel like is important that the doctors should share, especially to this black community that's in here. From an emergency medicine standpoint, a lot of times we go to the ER to check our heart, to check our bowel movements, to check all the things that we discussed, but we don't follow up. So, and then people return to the emergency department numerous times, and always you get the question of, well, I keep going to the ER, but they're not finding out anything. Would somebody like to touch on like the importance of following up when you think there's a problem?
Yeah, so I think this gets back to the importance of primary care. In the emergency department, they are just trying to make sure that you're not going to die and checking off some things. But I think to the point that we've talked about before, there's limited access. So people sometimes don't know about the value of primary care. They can't afford the copay when they go to primary care. So there are all kinds of issues. But we do know that if you can make that follow-up and sustain the relationship, that you will be more likely to really invest in your care overall and do some of the screening that we've been talking about today?
So my question is about hysterectomy. It's been about a year and a half, and I'm wondering what is there, if any information that you can give, what I should expect, what is to come when it comes to hormones. I've noticed a little bit of more weight gain with my diet not changing. So is there anything that you all can speak towards that?
Sure. Another audience member pulled me aside and asked the same thing. What we know is that if you've had a hysterectomy but saved your ovaries, it can thrust you into the menopause sooner if you were not yet menopausal. So that definitely is true. So it's not, I just said to her, it's not the hysterectomy, it's the alteration of the blood flow to the ovaries. So basically, if you weren't having those experiences before, then the decrease in your hormones, especially estrogen and testosterone, progesterone already, it starts to go down as we get older. You will notice women, when you are maybe late 30s and 40s, you start to get off with your period and go, I'm clockwork and I've never had that before. Well, studies show that upwards of 60% of the time you can miss ovulation. So that's why it can be delayed, So definitely have the conversation with your primary gynecologist and let him or her know what you are experiencing. And then it's also important, if you do have a hysterectomy and have your ovaries removed at the same time, one thing that I think we miss, as gynecologists miss, is offering, if you are a good candidate for it, offering patients estrogen therapy until you would have become menopausal, okay? There are 38-year-olds, 41-year-olds having everything removed because that is the definitive surgery and management for things like endometriosis. You take everything out. But once that endometriosis tissue dies off, and it's not just because you're experiencing hot flashes or night sweats, it's because of all the other things. And you've heard good information from the cardiologist, and I shared with the audience member, we catch up. Once we go through the change, we catch up when it comes to heart disease and those list of problems when you're menopausal. So we've got to work against all those things.
We have time probably for about 3 more questions, and then we're going to be standing around. You can come and ask this question. Before that next question, I want to get Brother Brown to talk very briefly, 30, 45 seconds about congestive heart failure. We have a lot of us. I know that's a 2-hour conversation, but just tell us something about congestive heart failure, what we need to do to.
30 seconds, Frank. All right. So congestive heart failure, which is what a lot of us kind of think about, is when the heart doesn't work properly, right? So there are different types of congestive heart failure. There's one type that we call systolic heart failure, when the heart doesn't squeeze well. And then there's another type of heart failure that we call diastolic heart failure, when the heart doesn't relax from the muscle being too thick. Now, when people talk about congestive heart failure, usually what they're talking about is the systolic heart failure. If they hear a family member has congestive heart failure, where the heart's not squeezing well, right? So one of the primary causes of congestive heart failure is having heart disease, right? So having blockages like we talked about, where the heart doesn't get enough blood supply, can actually weaken the heart muscle. You can have a heart attack, and that can leave you with congestive heart failure. Another thing that we see commonly, especially in African Americans and us, is a type of heart failure that comes from having untreated high blood pressure, right? And I'm telling you, I see that now in 30-year-olds. People are literally, probably last month, I probably saw 4 or 5 people under the age of 50 with congestive heart failure. And I mean, their heart's working at 10 or 15%, right? Because they walked around with high blood pressure for many years, never got it treated. And when your blood pressure is high, you got to think about your heart's a muscle. So at some point, your heart's trying to pump against this high blood pressure. At some point, it gets weak and it gives out. And sometimes, again, we call hypertension the silent killer. And we call it that for a reason. Your blood pressure can be extremely high. Your body can auto-regulate, and you might not get any symptoms until you've had in-organ failure, until you've had a heart attack, until you have a stroke, or until you have congestive heart failure. So definitely, congestive heart failure, we're seeing it more and more often, but one of the very treatable causes is hypertension.
All right, we got about 2 more questions, then we're going to shut it down officially.
Hi, good morning. First of all, this panel was absolutely great, and I hate that I missed the menopause section because that was really what I wanted to know about. But one of the questions that I do have continues with menopause is, how do we encourage the men to be a part of the process? Because it's a whole thing. Like, it impacts everybody. It impacts how we interact with him, how we communicate or not communicate, what they understand, what we don't understand. Because I've been doing some small talks with that, and I'm finding that men are even more confused on top of the things that they're already dealing with. So how do we encourage them to be a part of that? Because we're all trying to navigate in this brand new space.
I'm now down to 28 seconds. That is so loaded, but that is so excellent. We need to do more of this. We need to go into where we are. Maybe we go out to the communities and go out to the churches, have groups, have couples come and discuss. I mean, we didn't even really talk on the other part I was supposed to talk on today on female sexual health and dysfunction. I mean, when the woman is, the libido drops and she's having pain with penetration, it's hard for her partner, her male partner, who has been used to his wife or his partner initiating, and he's like, wait a minute, it's been 3 months and you ain't said a word? And what is their thoughts? Okay, and that is a whole conversation. I think it's excellent. I have invited patients to bring their spouses, their significant others into the room so I can explain what has happened to the vagina, what's happening when the testosterone gets low. It's really a needed conversation. And as a woman, if I don't understand that that's what's going on, how can I then relate that to my loved one?
Last official question, but again, we're going to be here to answer some questions.
Yes, this is an excellent panel. One of the things that I want to talk about and ask you a question around cardiology. I had a situation with my mother last year, and I found there is true medical disparities in the black community. And actually, the hospital that's located in Pennsylvania actually closed down abruptly. And my mom went to the hospital, and she kept saying something was wrong with her. And when we got into the ER, they automatically said they may have to shock her heart. And as she continued to keep saying something was wrong, another nurse came in and said, oh, well, she might just have a left heart blockage. She could go home. And I said, no, something is wrong with my mother. And if it wasn't for the black nurse and the black doctor who finally came in, because we brought her back, and I said, either they're writing my mother off or they just don't care. And he asked a series of questions. He said, your mother had a stroke. And from there, he said, I'm going to write all of the orders, and the cardiologist on the floor is going to have to follow my orders. And he saved my mother.
Wow.
And what we found out was that my mom's heart rate was down to 20%. And we end up sending her to University of Penn for her treatment because I didn't trust that hospital. So one of the things that I want to ask, how can you begin to help people in the black community to advocate, to push? Because I really pushed. And I said, I am an educated woman. I am a doctorate level woman. But I am not going to sit here and let you just write my mother off. And that would have happened that day if we weren't persistent and did not leave the hospital.
That's another great question. We could spend the whole day speaking about that. And actually, that's what Jada talks about and others about health equity. So it happens too often. It happens every day in hospitals. One of the things that we can do, and this is what I'm very passionate about, the best way to eliminate health disparities in the black community is to create more black doctors and healthcare providers. And so we have to be passionate about doing that, and nurses and therapists and everything, because we talk to each other. We have the same life experience, lived experiences. And so we will communicate with each other. We'll talk to each other. So it has to start with us. And so I know that's not the perfect answer. You're exactly right. We hear that every day. But
Frank,
the best way to create it, the best way to eliminate it is to create more of us.
Frank, she actually answered her own question. We have to be our own advocate. Oh, yeah. Is that better? Yeah. You answered the question perfectly. The families have to be their own advocate. You can't rely on doctors to tell you everything. If you're not happy with what's going on, then you need to go. You have to find someone else, or you have to go to the patient advocate at the hospital. You have to be satisfied with your loved one's care. You have to be your own advocate.
So, okay. I always like to finish my little panel discussion webinars with something. I always get in trouble for doing it. But we're going to give each person 30 seconds. We weren't supposed to get out of here until 12:30, so we're ahead of time. 30 seconds to make one last comment that they would like to make about whatever you want to talk to. Whatever you want to say.
All right. Thank you. This panel has been great. As far as dentistry is related, I would urge everyone to at least see their dentist at least twice a year. That's every 6 months. Like we talked about, risk factors that grossly affect dental hygiene and dental care, smoking, cigar smoking, smokeless tobacco, all those things. The mouth is the main gateway for the rest of your body, so be mindful what you put in it. Thank you again, Frank, for having me. And
Thank you
any
for
questions, I'll
participating.
be around.
Okay. Get yourself checked. If you're over 45 and you haven't had a colonoscopy, go get your colonoscopy. African Americans are 20% higher. We have a 20% higher risk developing colon cancer than whites, and 40% more higher risk mortality risk, meaning death risk, than all other people. We have probably we're diagnosed at a later stage, and we tend to present with symptoms in the what's called the right colon, which is pretty much asymptomatic. So by the time you come in, if you wait too long, it's spread beyond the colon. So if you learn nothing today, get your colon checked. If you have any symptoms of blood in your stool, go see your doctor.
Well, first off, congratulate everybody for being here and sticking around. You know, this is the first step is being involved in your own health. So that's the main thing, and I'm proud that everybody's here doing that. Second, from the orthopedic standpoint, movement is key. You know, the time you stop moving, that's when everything goes downhill. So just stay active, even if it's going outside, walking for a couple minutes a day. That helps tremendously with your bones, but it also helps tremendously with your blood pressure and all these other things that we've all been speaking about. So movement is key. Continue to, find out more about your health and continue to be your own advocate.
From a cardiac perspective, first of all, knowing your risk, knowing if you have a family history. Secondly, if you have any of those risk factors for heart disease, making sure you control those. Know your numbers, know your blood pressure, know your hemoglobin A1C if you have diabetes. When you go to your doctor, always get your cholesterol numbers. Know what your cholesterol is. Exercise. Take your medicines. And eat right. And my people, my patients ask me all the time, well, doctor, you say eat right. What does that mean? I tell them, if it tastes good and it smells good, it's probably bad for you, so just don't do too much of that. So everything in moderation.
All right, regarding high blood pressure, I would say that uncontrolled high blood pressure is something that will put you at risk for so many other medical problems. So we encourage you, every adult should have your blood pressure checked at least once a year. The uncontrolled high blood pressure can lead to something we didn't talk about today, chronic kidney disease. So if your doctor offers you a blood test and a urine test to diagnose kidney disease, take it. Take that test so that they can plot you on the chart to determine what your risk is. If you don't know if you have a risk or not, check out the National Kidney.org. It's the National Kidney Foundation. It'll give you a quick quiz. You can put your numbers in there to determine if you're at risk or your family member is at risk. And then I need to mention stroke briefly. What I want you to walk away with is the word FAST. I want you to know how to diagnose it if it was you or a family member. The word FAST stands for face. If someone loses, they're not able to smile, can't close their eyes, that is a medical emergency. A is for arm. Can you lift your arm? Can you move your hands? What can you do with your body? S is for speech. Has your family members started slowing down their speech? Are they understanding the words that come out of your mouth? And last is T, which is time. Time to call 911, because honestly, this is a life-threatening condition that actually there are some treatments that can help you if you get to them quickly. So that's all that I have, and I'll be around to talk with you more about high blood pressure.
All right, my take-home points for you. The secret is that there's really no secret. Advocate for yourself, live your best life. In the 80s, there was a study done at the University of Minnesota with about almost 700 Roman Catholic nuns, all right, so no black people. And what they did is they looked at their diaries and they gave a memory test, and these nuns donated their brains after they died. Here's what they found. Some of the nuns had evidence of Alzheimer's, strokes in their brain, right? And their memory was terrible. Then some of the nuns had evidence of Alzheimer's, strokes, and their memory was just fine, perfectly fine. So you do not have to be a prisoner to the idea that if you have Alzheimer's or some cause of memory loss that you're going to go down the tubes, right? Your brain can have disease, you can have these problems, and you do not have to have symptoms, right? Here's the key. Live your best life, mind what you eat, exercise, engage in positive and meaningful social relationships, and always stimulate your brain, always learn something, okay? So just because it's out there and you have higher risk, it doesn't mean that if you have it, that you have to have symptoms.
Awesome. My one thing is that get and see a primary care doctor. We've already talked about that these are the best and most impactful doctors that you can have, and they can connect you with these wonderful specialists. The second message is that as we've talked about, that healthcare is different for us, but there are things that we can do, and that means advocating and speaking up for ourselves, understanding our bodies, and when something is not right, that you say that to your doctor, and if they're not listening to you, to find another one. So that's my message for you all today.
You guys have heard some fantastic messages. I'm going to echo a lot of what they said. Diabetes and obesity we know is extremely prevalent in this room right here. There are about 38% of us that have pre-diabetes. Okay, so y'all can do the numbers. A lot of us don't know it. Diabetes affects blacks at a rate of 2 to 5 times more so than our white colleagues. So get yourself checked. Go to a primary doctor. Ask for your A1C. Ask for your lipids. Get your fasting blood sugar, and know there are a lot of treatments out there now for both diabetes and obesity. It's not days gone by where grandma put on insulin and then she died, okay? There are plenty of other treatments out there now that have benefit for your heart, for your kidneys, and everything. Get screened.
Thank you. So I am going to piggyback off of screening, but this is as it relates to mammograms. I cannot impress it enough upon you how important it is to get your mammogram. I like numbers, so my takeaway is always 7 or 22, because you know why. 7 people, any women in your family, mothers, sisters, cousins, aunties, grandmothers, we're going to encourage them if they are over the age of 40 and they would seek treatment if they were diagnosed with the breast cancer, that they should continue to get their mammograms and they should get it annually. So my call to action is that for whoever can hear me, and my sorors, I see you, so I know how to find you. 7 women. You're going to go and encourage them to get their mammograms. You're going to go with them if they have concerns, if they're afraid of getting their mammograms, because mammograms are really the best tool for us to save lives.
So I'm going to piggyback off of everybody as far as screening. I think that's what everyone is saying. You got to be screened. So for the men, if you're over 40, 45, see a urologist. Just establish. Get your PSA. Get a rectal exam. Talk about your erections. Talk about your urinary issues. And also for my females, I did not talk about it. It is not common. It's not normal to leak. It is common to leak urine, but it's not normal. So if you're having issues with overactive bladder, with stress urinary incontinence, don't think you have to live in pads. Come in, talk to someone, get treated.
Thank you. And my take-home message has very little to do with menopause, but for the women who are menopausal, whether it is you, whether it is your sister or your mother, we already described what the definition is of menopause, right? How many months without a period? 12. So if you start bleeding in month 15, see a doctor. If you start bleeding 3 years later, see a doctor. Do not come and say, it was just a little spotting. Black women are more at risk for endometrial cancer. So if you remember talking to your auntie last month and she mentioned it, get her to a doctor. I'm not telling you it is going to be cancer. Only 20% of the time it is. But I don't want you to hang your hopes on that. Get a biopsy. Okay, thank you.
Well, first of all, I want to thank the audience for being here. I want to mention just a few things, just to summarize kind of what people said. No, get a good primary care doctor, get a calcium scoring CT, get your PSA level, get your lipid profile, including lipoprotein A, and ask your doctor about putting you on statins, because you probably need to be on statins. Get your colon screening, lose weight, exercise regularly, stop smoking, stop drinking, especially the cigars, bruhs. Get enough sleep, protect your mental health, monthly self-breast exams, mammograms. Women get your, and men, young men get your HPV vaccine and lose weight. If we do that, we'll be much healthier. So thank you to the audience. Thank you to the doctors. Thank you to the leadership at Delta Mu Mu chapter, our bossless Fred Thomas, Justin Valentine for coming up with this idea. It's been an amazing activity. And we've all done some videos. I didn't do any. They did some videos that are going to be up on our YouTube page at some point in the future to hear some of these things. Thank you so much. Go out and enjoy the rest of SNS. Thank you.
You said 222 to
222, yeah.
Yeah.
Please go to, what number? What's the number? Please go to Morehouse School of Medicine booth to get some screening done, free screening.